Hello everyone, I'm Dr. Sambhav Shah. I'm a consultant spine surgeon in Mumbai. Today I'll be showing a case of a uniportal interlaminar discectomy for L5-S1 superiorly migrated disc. The sagittal MRI shows that there is a superiorly migrated disc which has gone up right up to the pedicle of the L5. There is a mild retrolisthesis at the L5-S1 level. However, patient presented with only left leg complaints. So on the axial MRI, you see even in the lateral recess, there is a bulge of a disc with a superiorly migrated disc right up to the pedicle. Now, conventional techniques, we will have to do a L5 laminotomy, resect the whole flavum. We may have to do a laminotomy right up to the pars. However, this is where endoscopic surgery plays a very important role, wherein if I am able to remove this piece of disc without causing any removal of the surrounding structures. So here, as you see, we have entered the interlaminar region without doing a laminotomy. I will use the slope of the L5 lamina and go underneath it to try and retrieve this piece of disc. So here we will not be doing any laminotomy. We will only be removing the amount of fluid required to do this procedure. So this is the most important thing about endoscopy. So once we are in, you see there is some soft tissue. I would recommend that you should always use the RF first before removing any kind of soft tissue, because once bleeding starts at endoscopy, it just takes away a lot of time. Once the soft tissue is cleared, you see the white area, which is your yellow ligament, the ligamentum flavum. So I'm using my probe to palpate the surrounding structures, where the lamina is, whether the lamina is in the way, or is it just the ligamentum flavum. Once this is done, then we will start the procedure by making a rent in the ligamentum flavum layer by layer with the annular cutter. Once the superficial layer has been cut, you see the deep layer of the flavum. Here I will be using my working sleeve to try and stretch out the flavum to use the flexibility of the flavum and then make for the rent and go in. Here you see the epidural fat now, and we will be, in this case I want to go superior, so I will be making more cuts superiorly and laterally, again using my working cannula to stretch out the flavum, so to even minimize the resection of the flavum. Once this is done, we start cutting superiorly and laterally to create some space to go in. And here I will be using my RF probe to even palpate where the medial facet is, where the nerve root is lying. So I'm using my pen-filled dissector to try and see whether I am lateral enough or not. And using my kerosene punch to remove the lateral part of the flavum. So again, you remove as much flavum as required to create an access into the epidural space to retrieve that piece of disc. Once you are comfortable, then you go into the epidural space. So removing more of the flavum laterally to create more space, as I don't want to mobilize the nerve, create a lot of tension on the nerve, which can damage the nerve. Now, since it's a superiorly migrated disc, I'm also removing a part of the flavum attached superiorly. Mind you, we have not done any lamina removal, we have not done any burring in this case. It's just the interlaminar window where we are going from. Bleeding can be controlled with RF probe, so RF probe is very important. Now you see here the epidural fat is present. I'll be using my pen field also to remove a part of the epidural fat and resecting more of the ligamentum flavum laterally. Important thing is to see the lateral border of the nerve, and once this epidural fat is removed, we'll be able to understand the anatomy much better. I'll be using my RF probe to cauterize the epidural vessels which are in the epidural space here. Again, I'm not sure about my anatomy as of now, so I'm using the probe to feel the surrounding structures. However, on palpation, it feels like we are not still lateral to the nerve root. Hence, I'm using the kerosene now to remove more ligamentum flavum laterally so that we are safely on the lateral border of the nerve root. It's important to create enough space so the manipulation of the nerve root is at the minimal. In case in this situation, if I feel that there is not enough space, then I even don't shy away from boring the medial part of the facet or the superior facet. Now, using the Penfield dissector, I am checking if I'm able to palpate. It was still quite difficult, and hence removal of more ligamentum flavum. With the Penfield dissector, you should easily be able to, move the nerve root away. If you feel any tightness, do not try to force any retraction. So now, as you see here, I see that there is the lateral border of the nerve superiorly, the dura as well as the nerve root, and I am able to mobilize it medially with the Penfield, and this suggests that my lateral dissection is done. And the minute I am trying to mobilize it medially, you see that there is a whole disc fragment which is coming into my vision. This is what happens with huge disc fragments. The minute they get space, they just want to come out. So we see a small disc fragment here which has been removed. This does not mean that we've got everything, so don't get excited when you see such fragments coming out. This could just be the tip of the iceberg. Now, using a nerve hook, I'm trying to see if there is any more, and now the anatomy makes more sense. So what we felt initially, that we were not at the lateral border of the root, actually was the bulged disc below, and now you can see the lateral border of the nerve quite well, and you see that's the disc laterally to it. So I am safe laterally, and there is enough space for me to work. And now, after removing the first fragment, you can see things a bit more clearly. So from 12 o'clock to 3 o'clock is the nerve root. What you see down here is the epidural vessel on the disc. That's a disc bulge, which was preventing us from retracting initially. However, we need to be sure what we are dealing with. Sometimes these discs look like the nerve and the nerve looks like a disc. And what you see, that hole is most likely the annular tear from where the fragment has migrated superiorly. So we have not made any rent in the disc. However, we do see a tear over there in the annulus. So that's most likely the tear. And now I'm going superiorly towards the axilla, and we can see something white over there, which most likely is the disc fragment. Now just turning my cannula a little bit more in order to keep my nerve root more free and medially retracted, so it's safe away from my instruments. Always use your RF probe, even though it's time consuming to change instruments, but it's important because once it starts bleeding, it is more difficult to control it, especially when you are around the nerve root. So I can see there is a disc fragment over there, which is in the axilla of the L5 exiting root. So in this situation, you have to remember that our target is the L5 nerve root, not the S1 traversing nerve, but the L5 exiting, as the disc has migrated superiorly. And now you see, after using the nerve hook, that piece of disc has come out. Again, it's a very small piece. I do see still more fragments. So a lot of times in these migrated discs, you don't find one big chunk, but there are multiple fragments which are lying over there. So it's very important to not end your surgery thinking that the nerve has been decompressed. The more you clear out the disc, the more the epidural fat comes into your vision. If required, you can remove it. So we do see a hollow over there. So you see the annular rent at the 5 o'clock area. Above that that's the annulus, which I just touched. And now we are above, posterior to the annulus, into the epidural space. and hunting for further more fragments. I'm still not very convinced, as on the MRI it was a huge piece. However, we have just removed minute fragments, so definitely there is more disc over there, which is now visible even better. You see there is a whitish area which I see there, which is where I'm using my probe now to try and dissect it, to try and free it. In chronic cases, sometimes these disc pieces are difficult to remove as there are a lot of adhesions around them. So make sure that you are clearing off the piece from all the adhesions all around. And now I'm using my nerve hook. So the fat which you see above most likely is the fat near the exiting nerve root, and that's the disc which we have milked out, and that's most likely one of the big fragments now coming out. So it was hiding superiorly, and that was quite a big fragment. So even though I'm trying to milk it out, it's getting difficult. Sometimes these fragments don't come out through the working channel of the endoscope, and in that case you have to remove the whole endoscope out. So once we go back in, sometimes you can find more bleeding. But fortunately for us, there is not much bleeding, because once you remove the piece, sometimes the epidural vessels start bleeding. So we see that there is more whitish discal material present over there. Once that fragment is removed, now you see the epidural fat which is lying near the exiting nerve root is much more mobile. However, there are still whitish fragments seen over there. So there was one big fragment along with multiple smaller fragments. Sometimes even though we don't remove the small fragments, the patient is still asymptomatic. However, if you visualize, whatever you visualize, try and get maximum of these fragments out. You see the exiting nerve quite beautifully. I can even see the palpations of the exiting nerve, so I think the major fragment has already been removed, and these are all smaller fragments now which are coming out. So as you saw here, this small fragment was thrown away by the pulsation of the fat and the dura. So you can see the exiting nerve quite beautifully now, going from 12 o'clock to 9 o'clock, and the axilla seems completely free. We do see some whitish area, however, that could be even some posterior longitudinal ligament over there, or some adhesions remaining from the chronic compression. So there are still small fragments remaining over there. So make sure, don't try to be in a hurry, and make sure that you've not left any fragments behind. So our most important part of the surgery is now over, which was decompression of the L5 exiting nerve root by removing the superiorly migrated L5-S1 fragment, which was compressing the exiting L5 nerve. It's also important to check for any loose fragments in the disc space as well. However, I do not try and push my disc forceps inside the disc space too much. Only if there are loose fragments lying around the disc space, we just try and remove those. However, do not be very aggressive in trying to remove the normal disc remaining in the L5-S1 disc space. So we are still getting a couple of loose fragments which were in that area. The question is always asked, what's the end point? Well, I think the end point is when you see good pulsations of the nerve root. In this case, in case we forgot a few of these tiny fragments over there, I don't think it would matter symptomatically, as the fragment, the big fragment which was causing the major compression was removed, and we are seeing good pulsation over there. So even though these smaller tiny fragments were left behind, I don't think symptomatically it would have mattered. You see here, we are going on getting multiple fragments coming out from the axilla of the L5 nerve. Spend some time over here. Make sure you've gotten everything. I do see a white thing still bulging there. So again, these are just small fragments which are lying around over there. Now, since you see how the epidural vein let out the minute you remove that fragment, and even the pulsations have gotten better. So actually, it was important to remove these fragments. Now, using the RF probe, I am just checking for further areas of if there are any fragments lying around laterally. Zooming in again into the axilla with the probe, trying to probe further for fragments. Again, we see something whitish there, not sure whether it is part of just the PLL or is there a fragment over there still. Using the nerve hook to probe further. So it feels like what I was feeling there with my nerve hook was something which was stuck to the body of the L5. So sometimes in the superiorly migrated fragments, these fragments they also go in under the PLL. So they are quietly hiding over there. So the more you remove, the more you visualize, and sometimes the more fragments you can discover. You can see the origin of the L5 nerve over there now from the dura going down. Very good pulsations here. I'm not going to trace the nerve into the foramen as there was no compression or foraminal disc. It was mainly paracentral. Now we are turning towards the traversing nerve. We are on the disc space. So our job of decompressing the L5 nerve is over. That was the annular tear which was already present from where the disc has sectoted out superiorly. So as you see, the tear is also towards the inferior end plate of L5. That's the disc space seems a bit bulged. However, the traversing route is mobilized medially quite easily with my outer cannula. The rotation of the cannula also should be done gently. Only if you have, there should not be any force applied in the rotating maneuver. It should be quite smooth and gentle. I'm just probing the disc space to see whether it's just a bulged out annulus or if there is any fragment lying over there as well. So on the MRI scan at the disc space also we did see a protrusion of the disc. So I am going to check on the endoscope. It does feel like there is a protrusion, that there is like a hump below the nerve root. So only if I feel that it's compressing, then we will open up this as well. So in this situation, it did feel like it was compressing the nerve, or it was at least bulgy underneath the nerve. So it's better to just once check it out. Let's see, there are not any big fragment which coming out. Once I inserted the disc forceps, I felt that there were no loose pieces, so I'm just using my nerve hook to check if there is any loose piece which can come out. On further probing the disc space with a pituitary, I don't find any free fragments. I think this is the end of our surgery. On derotating the cannula again, you can see the whole traversing route quite free. So we have decompressed the exiting L5 nerve root and the traversing S1 nerve root over here. You can see the preoperative and postoperative MRI. The whole piece has been removed quite well without dissecting any majority of the flavum. Neither we have touched the lamina of the L5, neither the medial facet. So this is truly a surgical strike of the disc.